السلام عليكم أحبتي الطلاب المرحلة الخامسة. نكمل وياكم اليوم المحاضرة الجزء الثاني من المحاضرة اللي هي حول bleeding disorder. معكم دكتور حيدر سعد القاسم consultant physician medical oncologist. We stop on clotting factors abnormalities. Let us continue. Clotting factor abnormalities, as you know, the most common clotting factors abnormalities is hemophilia, and hemophilia A and B. But in a clinical practice, von Willebrand disease could be also a common disorder, especially in young age female. Acquired disorder, we have vitamin K deficiency, and this could be nutritional, malabsorption, could be side effect of medication like anticoagulant and warfarin, and could be due to chronic liver diseases. Let us talk about von Willebrand disease. As I mentioned before, von Willebrand factor is essential for clotting system to synthesize by the endothelial cell surface of the blood vessels. It is autosomal dominant in most of the cases. Type 1, most common type, 70% of all cases. Prolonged bleeding time, normal platelet count, decreased plasma, von Willebrand levels, and secondary decrease factor 8 levels. Why? Because von Willebrand factor is a carrier for factor 8. We are scheduled for classification of von Willebrand disease. And as I said, type 1 is most common type, about 75% of the cases. This is quantitative defect. Type 2 is a qualitative defect, means quantity, amount of the factor, quality, type of the factor defect. If we note the comment, most of the cases are treated by DDAVP, which is desmopressin, which is a drug of choice. We should concentrate on type 2B. In this type, we note that patient presented with thrombocytopenia, and this type can be or should be differentiated from immune thrombocytopenia. In this type, we should use vasopressin with caution because it can cause more platelet deficiency. In type 3, which is severe quantitative deficiency, here the desmopressin is of no value. Hemophilia A, hereditary disorder, it is X-linked disease. 30% runs in family with 30% have no family history, new mutation, so could be negative family history. 15% severe cases develop factor 8 inhibitor, decreased amount or activity of factor 8. Factor 8 is cofactor for factor 10 in the coagulation cascade, and the symptom is mild, moderate, severe form of factor 8 deficiency when the factor percentage or concentration below 1%. So question here, what's the base lab diagnosis? Lab test most useful to monitor patient. Base lab diagnosis factor 8 assay. Lab test monitor the patients is PTT. It depends on factor 8. And what are the chances of heterozygous female to having disorder? This question for you. Mild hemophilia treatment is desmopressin. Desmopressin increase the synthesis of von Willebrand factor, and this is an increase carrier for factor 8, and so can decrease factor 8 level. How you calculate the required dose of factor 8 depend on this formula: body weight multiplied desired factor 8 increase, how much the percentage, depend what is minor, moderate, or severe. 20, 30, 60 multiply 0.5. This is the dosage of factor 8 that should be infused. We hear about prophylaxis for hemophilia A or B. Prophylaxis, we have episodic on-demand treatment or type of treatment about hemophilia, replacement with factor at time of bleeding. Continuous regular prophylaxis, we have primary, secondary, tertiary. Primary continuous prophylaxis start before age 3 years and before the second large joint bleed, so this is called primary. Secondary Continuous prophylaxis started after 2 or more large joint bleeds, but before the onset of chronic arthropathy. Tertiary, it is usually after starting of chronic arthropathy to prevent further damage. Intermittent periodic prophylaxis, replacement of factor given to prevent bleeding for short period of time, such as surgery. There is a new modality treatment of hemophilia A. This is emicizumab. MAB, it means monoclonal antibody, and this is approved by US FDA approval for individual with hemophilia A with inhibitor in late 2017 and those without inhibitor. But emicizumab is not effective for acute bleeding. Still, factor VIII concentrate is the treatment of choice. Hemophilia B, like A, factor IX deficiency, X-linked, less common, difficult to be differentiated from A, factor 9 level assessment, factor IX concentrate. This is important diagram how you differentiate between platelet disorder and clotting disorder. In platelet disorder, the major site of bleeding is mucous membrane, nose, GIT tract, while in clotting disorder, the major site are deep tissue joint, soft tissue, or hematoma. Petechiae common in platelet disorder, uncommon in clotting disorder. Ecchymosis, they may develop large ecchymosis. Clotting disorder may be significant depending on the degree of thrombocytopenia in the platelet disorder. Excessive bleeding after minor cut, yes. Platelet disorder, not usually. Clotting disorder, excessive bleeding with surgery or invasive procedure, often immediate, often during a procedure. So individual with mild disorder may not report significant bleeding. The last topic is DIC. DIC is disseminated intravascular coagulation, characterized by activation of the coagulation sequence, sequelae, tissue hypoxia, microinfarction that affect major organ of the body. So usually patient with DIC end with multi-organ failure. Trigger pathology, release of tissue factor, thromboplastin, widespread endothelial injury. Mechanism, activated monocyte, interleukin-1, tumor necrosis factor, consumption of coagulation factor, platelet, and fibrinolytic pathway. In DIC scenario, the patient usually present with bleeding tendency and could be thrombotic episode, depend on which system activated more, and usually DIC is secondary to underlying pathology, and usually it is not a primary. This is common source of DIC, which is the etiology: leukemic cell, placenta, delivery, carcinoma, bacterial toxin. Organ failure is most important cause of morbidity and mortality in patient with DIC. The most commonly affected organ are kidneys, brain, heart, and lungs. We have acute and chronic DIC. Acute DIC dominated by bleeding. Chronic DIC dominated by thrombosis. Lab test, both PT and PTT elevated, thrombocytopenia, low fibrinogen, and elevated fibrinogen degradation product or fibrin symbiotic product. Prognosis variable depending on the underlying pathology, degree of clotting, activity of mononuclear phagocytic system, and amount of fibrinolysis. And treatment, usually treat the underlying pathology. This is how we differentiate between chronic and acute DIC. These are lab tests to differentiate DIC, TTP, and primary hyperfibrinolysis. A major principle in the management of DIC is treatment of the underlying cause in order to eliminate the source of ongoing coagulation and thrombosis. Patient with purpura fulminant appear to benefit from, this is a trial, they said some patient get benefit from protein C concentration as part of treatment. Sorry, before finished, we should mention liver diseases as a cause of bleeding disorder. And as you know, patient with decompensated chronic liver disease having tendency for bleeding. Why? Because all the clotting factors synthesized by the liver. So patient with chronic liver diseases having tendency for clotting abnormalities. Also platelet abnormalities mentioned in patients with chronic liver diseases. Why? Because portal hypertension causing splenomegaly, hypersplenism causing consumption of a platelet. So both bleeding disorder due to platelet dysfunction or thrombocytopenia and due to clotting abnormalities seen in patients with chronic liver diseases. And by that I finish the second presentation for our topics, bleeding disorders, and I am happy to hear from you any comment or question, and thank you very much.